colleagues hesitate which language I have to speak because I don't see so many foreign participants, but anyway, it's a pleasure to open the plenary session, and I would ask my colleague to be sharp in time because I have many things to do afterward, and it's a special pleasure to announce the paper of Jeffrey Rubnitz, Modern Strategies in AML Treatment. Jeffrey.
Thank you for the invitation to speak today. It's an honor to be here. I'll try to stay on time since we're running late. So my topic today is modern treatment strategies for AML, which is quite difficult to cover in 20 minutes. So I'll just try to highlight a few of the significant findings over the past several years. First, highlight some results of recent clinical trials for talented AML, discuss the heterogeneity of AML, talk about minimal residual disease in AML, and then just very briefly touch on future directions and new agents. When we look at the outcome for children with AML, you see this shows the results from St. Jude Children's Research Hospital. In the 1980s, about 33% of children with AML were cured of their disease. In the 1990s, we did a little better with survival rates of around 55%, and achieved about 70% survival in her most recently completed trial, AML-2, which ran from 2002 to 2008. So good result, but not nearly as good as we've seen for childhood acute lymphoblastic leukemia. Now, while we think about ways to improve therapy, we must keep in mind that not all failures are from relapse. Relapse is the most common cause of failure. So in our AML-2 study, about 20% of patients suffered relapse of their disease, but nearly 10% of patients died of toxicity. Some patients died of toxicity after chemotherapy, and others after transplantation. So as we think about new therapies, we want to develop therapies that would both increase the rate of relapse as well as provide safer therapy and decrease the rate of toxic death. Now, the results obtained at St. Jude are very similar to results from other study groups. Popular groups from around the world, Asia, Europe, and the United States, have reported very similar results. So one example is the AML BFM 2002 trial, which reported an overall survival of 74%. So very similar results. Event-free survival was 55%, overall survival was 74%. But this study highlights one of the problems that we have in childhood AML. When you look at most randomized trials conducted over the past 20 years or so, most randomized trials have shown really no difference in the two arms, and as a consequence have not resulted in significant changes in therapy. So this study was a randomized comparison of liposomal domino, or Donazone, during induction versus irinotecan during induction. And you can see the results show really no significant difference with event-free survival of 59% for patients who received liposomal doxorubicin versus 53% for those who received irinotecan during induction. So very good outcome, but no difference in the two arms. Now, the Children's Oncology Group reported similar results. These are the results of the AML 531 study, in which patients were randomly assigned to receive standard chemotherapy or standard chemotherapy plus 3 courses of Mylotarg, trastuzumab ozogamicin. And although there was a event-free survival benefit for patients who received Mylotarg, there's no difference in overall survival. Patients who received standard chemotherapy had an overall survival of 65%, whereas those who received standard chemotherapy plus trastuzumab ozogamicin had an overall survival of 69%. So we've got a very large randomized study with no difference in the two arms. And this has been true for many studies conducted over the past 10 to 20 years. So a few of these studies are highlighted here. The MRC AML-12 study compared mitoxantrone versus daunorubicin during induction therapy. This is a large study that enrolled over 500 patients over a 7-year period. The BFM 2004 study that we just described compared donazone or liposomal daunorubicin versus irinotecan during induction therapy, and again enrolled over 500 patients over a 7-year period. The the St. Jude AML-2 study compared high-dose ARC-based induction versus low-dose ARC-based induction, and we enrolled about 200 patients over a 6-year period. And then the COG study that I just mentioned was a randomized comparison of chemotherapy versus chemotherapy plus trastuzumab or ozorgamycin, enrolled 1,000 patients over about a 5-year period. These are very large studies, these large numbers of patients. These were the major studies in the respective countries that were conducted over a 5 to 10 year period. And the results, although quite good in terms of overall survival, were disappointing in that there were no differences in outcome between the two arms. So we found, as a result of these studies, that it doesn't really matter which anthracycline is used during induction. Idarubicin, mitoxantrone, daunorubicin, and donazone are roughly equivalent when used at equivalent doses. The same thing with Aracetamib. We found in our studies that high-dose Aracetamib was equivalent to low-dose Aracetamib when given during induction therapy. And then in the COG study, there was really no difference overall between patients who received standard chemotherapy versus those who received standard chemotherapy plus trastuzumab or ozorgamycin. There was an advantage for certain subgroups of patients. So what are the reasons for this lack of success? Why are we not seeing differences in these large randomized trials? Well, one reason is lack of new classes of agents. We're comparing different forms of anthracyclines. We're comparing different nucleoside analogs or different doses of nucleoside analogs. With the exception of the Maltarg study, we're not really testing new classes of agents. Another reason is lack of targets. As we'll discuss in a minute, there are fewer mutations that we know about in childhood AML compared to adult AML, and even some of these mutations, such as FLT3 ITDs, are not always the drivers of the leukemia. Small patient numbers, especially when we're talking about specific subgroups of patients. And then one big reason we're not seeing differences in these large studies is because of the heterogeneity of AML. Because AML is such a heterogeneous disease, we might not see a beneficial effect if that effect only applies to 10% or 20% of patients. So a few words about the heterogeneity of AML. So this is a pie chart from a review article that my colleague, Dr. and I published several years ago, showing that AML is really more than one disease. It's a very genetically diverse disease with a variety of translocations, some that are associated with a good prognosis, as well as a variety of point mutations. It's a very heterogeneous disease. And our studies generally are randomized studies that treat all patients the same without regard to genetic subgroup. The heterogeneity is becoming more complex as we've learned more about the genomics of AML over the past several years. We've seen the complexity is even greater. So this is from a review article published in Blood a couple of months ago. The numbers are for young adults with AML, but the same principle applies to children with AML. And we see a very complex disease with a variety of translocations and point mutations. And we see that even within genetic subgroups, there are subgroups within the subgroups. So for example, patients with A21 translocation are not all the same. There are at least 3 different genetic subgroups within the subgroup of patients with A21 translocation. Similarly, patients who have mutations of the NPM1 mutation are not all the same. There are at least 6 distinct genetic subgroups within the NPM1 mutated patients. The heterogeneity and the problem in developing new therapies is even more complex when we look at the functional categories of mutations. And this is from an article published in the New England Journal last year, showing that there's a variety, not only a wide variety of mutations and genetic alterations, but these have different functions. So one common mutation that we see in AML is mutations of the FLT3 gene. And so this is mutation in tyrosine kinase receptor that leads to abnormal signaling and proliferation through a variety of pathways, the RAS pathway, the PI3 kinase pathway, and JAK-STAT pathway. Now, if all mutations were mutations in tyrosine kinase inhibitors, the problem wouldn't be quite as difficult. We could develop a variety of tyrosine kinase inhibitors and target these mutations. But the problem is these mutations and genetic alterations affect different pathways. So in addition to the tyrosine kinase receptors, we see mutations that affect DNA modification, mutations that affect methylation. We see mutations and alterations that affect gene expression, and we see mutations that affect the localization of the NPM1 protein. So we see not only a wide variety of genetic alterations, but a wide variety of functional consequences of these mutations, making it very difficult to develop new therapies. The heterogeneity of AML is, I think, well exemplified by this example. This is a study performed by Kim Klein, an international collaborative study that was published in JCO last year. So Kim pulled together over 800 cases of childhood AML with A21 translocation and looked very carefully at the genetics of these cases. She found, for example, that patients who have deletion of 9q have significantly worse complete response rate, complete remission rate compared to patients who did not have deletions of 9q. More striking was the impact of the gain of chromosome 4. We see that patients who had extra gain of chromosome 4 had a very high relapse rate, with about 50% of these patients suffering relapse. So although we know that in general A21 is associated with a very good prognosis, patients who have A21 with addition of chromosome 4 really have a quite poor prognosis with a high risk of relapse and correspondingly low event-free survival and overall survivals. Kim also showed that the outcome of patients with A21 positive AML really depends on treatment. And this is not surprising since A21 is known to be a type of leukemia that's sensitive to chemotherapy. So her study showed that higher doses of anthracycline, higher doses of etoposide, and higher doses of ARC are associated with a better, given during induction, are associated with a better outcome among patients with A21 positive AML. So of course, outcome of any subgroup really depends on the treatment given. So what's really the best predictor of outcome? We need a predictor of outcome that takes into account the therapy given, the biology and genetics of the leukemia, and the biology of the host. And the best way to do this is responsive therapy, or minimal residual disease, because that really takes into account all these factors. So there are three main methods that are used to study minimal residual disease in AML. The method that we use and that's used most commonly is flow-based detection of abnormal phenotypes. Another method is RT-PCR detection of abnormal transcripts that can be done for specific subgroups of patients. And then more recently, and really more in the research setting at this point, but hopefully we'll move into the clinical arena, is sequence-based detection of leukemia-specific mutations, which allows the detection of multiple clones in each patient. One problem with, say, for example, flow cytometry is that you can follow one phenotype, but you may miss other clones that are present there that emerge at the time of relapse. So this shows the impact of MRD among patients treated on our AML-2 study. And this was the first study in which we used MRD prospectively to tailor the intensity of therapy. And we see that after one course of therapy, patients who had high levels of MRD levels greater than 1% had about a 50% cumulative incidence of relapse, whereas patients who had negative MRD or low levels of MRD had a very low risk of relapse. After two courses of therapy, any MRD was associated with poor prognosis. Even levels of 0.1% were associated with cumulative incidence of relapse of around 50%. Recent studies reported by the NOFO group for the AML 2004 trial also showed the very important impact and predictive factor of MRD. So the top two boxes show the event-free survival and overall survival according to MRD after one course of therapy. We see that patients who had positive MRD, even at the level of 0.1%, had significantly worse event-free and overall survival as compared to patients who were MRD negative. The impact of MRD was even more striking after two courses of therapy. So prior to consolidation therapy, patients who had even low levels of MRD had really a dismal event-free survival and quite a poor overall survival. So again, very important predictor of outcome using flow-based assay. Now, a recent report published in New England Journal from an adult group used RT-PCR analysis of blood, not of bone marrow, to follow levels of disease in patients with NPM1 mutated AML. And they showed the simple PCR test performed in peripheral blood was a very good predictor of outcome. The top two boxes show the impact of MRD among all patients with NPM1 mutations. We see that patients who are MRD positive have significantly worse survival and significantly higher risk of relapse. Now, a very important finding from this study is that MRD was important both in patients who had FLT3 mutations and FLT3 wild type. In the past, what we know from previous studies that the presence of FLT3 mutations is a very important prognostic factor among patients with NPM1 mutated AML. And here we see that even among patients who do not have FLT3 mutations, MRD positivity is still a very poor prognostic factor. So among patients who did not have FLT3 mutations, those who were MRD positive had very high risk of relapse, as is true for patients who are MRD who have FLT3 internal tanner duplications. So MRD, a simple MRD test performed in the blood can pick out patients who had FLT3 mutations who still did quite well, those who were MRD negative, and can also predict patients who were who had FLT3 mutations. Actually, patients who did not have mutations who did poorly because they were MRD positive, as well as patients who were MRD positive who did well because they were MRD negative. So again, showing that genetics is important, but MRD is really a better predictor of outcome. And one thing we worry about when we follow MRD by one method is that we might be missing a subclone that's present when a patient's in remission and then emerges at the time of relapse. And so Jeff Clow was not at St. Jude to perform these studies when he was at Washington University at Tim Lay's lab, and he studied clearance patterns of mutations by exome sequencing. And the idea here was to identify multiple mutations in each patient and follow each of those mutations so that you can really follow every clone, or at least many clones, within each patient. So the upper left curve shows one patient, just one example, where Jeff followed several mutations, several variants in this patient, and all of these mutations cleared by day 39 and stayed negative. So clearance of all variants tested. This patient is an example of incomplete clearance, where there was decreased levels of these variants, but not complete clearance, and then reemergence at the time of relapse. The middle two panels demonstrate that there are multiple subclones in some of these patients, and some of these clones are really the founding clone. It's very important to follow that founding clone, where there are other subclones that may not be clinically important. So here we see that there are subclones that disappear and stay absent, but then there are founding clones that are persistent throughout therapy. So founding clones here and here, and this patient also has several founding clones. So this study suggests that it's very important not to follow only the dominant clone of diagnosis, but really to follow even the subclones, especially the founding clone. And when Jeff looked at the pattern of clearance, we see this shows a pattern for all patients combined. These were patients who had eventually survival of less than 12 months. And we see a pattern where there's persistence of many of these variants, clearance but reappearance of many of these variants. Very strikingly different pattern when we look at patients who had event-free survivals greater than 12 months, where there's clearance of essentially every variant and very little reappearance of these variants. And so as you might expect, there was a strong association between clearance of the variants and event-free survival and overall survival. So patients who had persistence of these variants at day 30 had significantly worse event-free survival and overall survival compared to patients who cleared all of their variants. So what are the keys to effective treatment then? Obviously, we can't touch all aspects of treatment in 20 minutes, but some of the key elements are identification of high-risk patients. We didn't discuss this today, but we know that there are many subgroups that are at very high risk of relapse. Some of these are listed here. And it's important to identify these at diagnosis so they can be, these patients can receive either more intensive therapy or alternative therapy, experimental therapy, or hematopoietic stem cell transplantation. It's also important to closely monitor MRD. As we've seen, MRD is a very important predictor of outcome, even among low-risk or high-risk subgroups of patients. We didn't discuss it today, but intensive supportive care is very important, as 5 to 10% of our patients still die from toxicity. Hematopoietic stem cell transplantation, when indicated, is a very important component of therapy. The next several talks will discuss hematopoietic stem cell transplantation. We also must consider new agents, not only in the relapse setting where they're generally tested, but also in the upfront setting for patients we know are very high risk of relapse. So what are some of the new agents on the horizon? I'm not going to talk about these in any details, but I'll just briefly mention them. The immunotherapy, of course, is a very hot topic right now, especially in the treatment of ALL. CAR T-cell therapy is being developed for AML, several years behind that of ALL, but there are CAR T-cell therapies that are CAR T-cell clinical trials that are open now, using adults with AML, using either 123 or CD33 as targets. These trials are just starting to open. So antibody-based therapy, there are 2 agents that are in clinical trials now. There is an agent that's made by Cell Genetics. It's just an antibody conjugate analogous to Mylotarg, but with a different toxin attached to anti-CD33. That's in clinical trials right now. And another antibody-based therapy is a bispecific antibody, analogous to blinatumomab. Blinatumomab is CD3, CD19 bispecific antibody. Amgen also has a CD33, bispecific antibody that's right now is in clinical trials in adults and hopefully will enter clinical trials in pediatrics. They're later this year. either later this year or early next year. There are also new agents. There are epigenetic modifiers, a very hot topic over the past several years. Histone deacetylase inhibitors, some of the older ones, such as Rubnitz, as well as the newer ones, such as panobinostat, hypomethylating agents, decitabine and azacitidine, and then a new area of BET inhibitors, bromodomain inhibitors, are now in clinical trials primarily in adults with AML and other malignancies. Of course, tyrosine kinase inhibitors, sorafenib, lusartanib, quizartinib have been tested for patients with FLT3 drug-candidate mutations. One of the newer ones is prenolanib, which Dr. Nava has been studying at St. Jude. So there are new tyrosine kinase inhibitors that are being developed, which hopefully will help overcome the problem of resistance. One totally different class of agents is a drug called selinexor. This is made by a company called Karyopharm, and selinexor is a specific inhibitor of nuclear export. This has completed phase 1 studies in adults. That paper was published in JCO a couple months ago, and we have just completed a phase 1 study in pediatrics as well. So this drug is quickly moving into phase 2 trials in both adults and pediatrics. And very exciting is BCL2 inhibitors. There was a lot of interest in BCL2 inhibitors about 10, 12 years ago when antisense BCL2 was developed. And that was just not, it was a good target, but not a very good agent. Now there actually is a very good agent, venetoclax, which is a very potent BCL2 inhibitor that was recently FDA approved in the United States for the treatment of CLL. And preclinical and some clinical data suggest that will be very effective in AML as well. So in conclusion now, we see that AML is a very heterogeneous disease that makes it more difficult to treat. We've made some progress, but it's unlikely that we'll exceed the 70% survival rate with current therapy. We can't keep testing different anthracyclines and different doses of nucleoside analogs and different nucleoside analogs. We really must test new agents. And we must develop therapies that are tailored and targeted to specific subgroups because it is such a heterogeneous disease. Thank you for your attention.
Thank you so much, Jeffrey. The paper is open for discussion.
Question? Thank you very much for your presentation. I would like to ask you, do you see the place of hematopoietic stem cell transplantation in children with acute myeloid leukemia? And do you see the place of bone marrow transplantation, hematopoietic stem cell transplantation in children with acute myeloid leukemia?
In first remission, you mean? Yeah?
Not only first remission, but...
Yes, I didn't discuss it today because I think there are several talks coming up. Several speakers who will be discussing bone marrow transplantation, which is why I didn't discuss it today. But yeah, it's a very important part of treatment for AML. Currently at St. Jude, we transplant approximately 25% of AML patients in first remission. So we feel that it's a very important part of the therapy for AML. And so the only reason I didn't discuss transplantation today is that there are other speakers who will be discussing it. But yes, transplantation is a very important part of the treatment for AML.
And what is the current policy of St. Jude with regard to transplanted patients in first remission? Which patients are eligible,
yes, we transplant,
especially in the so-called intermediate risk patient? Do you still consider them as candidates for transplant or not?
So we transplant high-risk patients, although we define high-risk pretty broadly, as I showed on one of the slides. So we have quite a broad list of features that make patients high-risk. So high-risk translocations, 6-9 translocation, for example, other high-risk features, monosomy 7, secondary AML. We transplant patients who have megakaryoblasttic leukemia, and then patients who have positive MRD, either greater than 1% after one course of therapy or greater than 0.1% after 2 courses of therapy. So we do transplant about 25% of patients in first remission. We do not transplant patients with core binding factor leukemia or other low risk or intermediate risk leukemia.
Yeah. Well, I am from Bangladesh. Yes, here. Here.
Here, on the left. No, okay.
Yeah. I am Dr. Jawan from Bangladesh. You know, Bangladesh is a developing country. Well, considering your perspective of subclones or mutation, different mutations during the initiation of chemotherapy, in our perspective in Bangladesh, would you suggest kind of maintenance therapy after the blocks of therapies are completed, like AML12 by the MRC or thing like that? Because in my experience, lately we are giving maintenance therapy for 1 year after the blocks of therapy is over. And these patients are doing better than those who were just given the blocks of chemotherapy, the induction, and subsequently it was taken off. So what is your opinion or comments about this? Could I make you understand?
Well, is your question regarding maintenance therapy for AML?
Yeah, in our perspective, because we have little, resources to take all these measures, what you have taken. So, considering our perspective, would you suggest kind of maintenance therapy for AML? And
Yes, it's a good question regarding maintenance therapy for AML. I think since the relapse rate is so high, it does suggest that these patients do need more therapy rather than simply 4 courses of chemotherapy. But I think the problem is we don't know what good maintenance therapy consists of. We really don't know what the proper maintenance therapy is. You know, when maintenance therapy has been tried in the past, there was a large study from France published about 10 years ago. Patients who receive maintenance therapy actually have worse overall survival. So if we knew what maintenance therapy worked, I think patients probably would benefit because, you know, we stop therapy after 4 courses and 20 to 30% of patients still relapse. And we just don't know what to use for maintenance therapy.
okay.